Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Today, we're talking about the hidden dangers of some of the most common medications in the entire world, diabetes meds. We're going to explore how these life-saving drugs can in some cases turn into life-threatening emergencies.
And that really gets to the heart of what we're talking about today. Because in an overdose, these common medications become these incredibly complex medical mysteries, and doctors have to solve them against the clock, where, every clue and every single minute really, really matters.
So here's our game plan. We'll start with why these overdoses are just so uniquely tricky. Then we'll get into the specific puzzles of metformin, sulfonylureas, and insulin. And finally, we'll reveal the clever detective work doctors use to figure out which one is the culprit.
Okay, the first thing to get your head around is that we're not dealing with just one single problem here. An overdose of metformin looks completely different from an overdose of insulin. Each one has its own set of clues, its own symptoms, its own dangers. It's like a totally unique medical mystery every time.
So our first puzzle starts with metformin, which is, one of the most prescribed drugs on the planet. But in rare cases, like an overdose, or when other health issues get in the way, it can cause something called metformin-associated lactic acidosis, or MALA. It's this deceptive, really dangerous buildup of acid in the blood.
And what's so sneaky about MALA is just how normal the first symptoms look. Abdominal pain, feeling sick, dizzy, that could be 1,000 different things, right? It could just be a stomach bug. So unless a doctor knows the patient is on metformin, it's incredibly hard to diagnose until much later, when more severe signs like confusion start to show up.
Now, here's the thing about MALA. It almost never just happens on its own. It's usually triggered by some other condition, and the number one culprit is kidney dysfunction. See, your kidneys are what clear metformin out of your body. So if they're not working right, the drug can build up to toxic levels. And this is where it gets really tricky for doctors. You've got one study that suggests the actual amount of metformin in the blood is a key factor for survival. But then another study comes along and says, nope, the metformin level doesn't matter, it's all about how acidic the blood is. This kind of conflicting data makes it incredibly hard to know which patients are really in the most danger.
So how do you treat it? Well, there's no magic antidote you can just inject. It's all about aggressive supportive care, managing their breathing, their blood pressure. And for the absolute worst cases, doctors turn to things like dialysis, which is basically a machine that acts like an artificial kidney, filtering all that acid and poison right out of the patient's blood.
All right, our next puzzle involves a class of drugs called sulfonylureas. Their job is to basically hotwire the pancreas and force it to make more insulin. But in an overdose, this creates a really dangerous paradox where the standard treatment can actually make things much, much worse. So think about it this way. Normally, your pancreas only releases insulin when it senses that your blood sugar is high. It's a smart system. But sulfonylureas, they just blow right past that whole feedback loop. They basically go straight to the pancreas and jam the release insulin button, forcing the floodgates open, whether your blood sugar is high, normal, or already crashed. So if a patient shows up with dangerously low blood sugar, that's called hypoglycemia, the immediate textbook response, the first thing anyone thinks to do is give them sugar, usually right into their vein with an IV.
But in a sulfonylurea overdose, that simple, obvious, life-saving fix, it's a trap. It can kick off a vicious cycle that's incredibly hard to stop.
And here's the paradox in action. When you give that IV sugar, the rise in blood sugar signals the already out-of-control pancreas to dump even more insulin into the body. And the result is this rebound hypoglycemia. The patient's blood sugar just crashes again, and often it goes even lower than before. It creates these wild, dangerous swings that are a nightmare to manage.
So, to break this cycle, doctors need a much smarter tool.
They use a drug called octreotide, and you can think of it like an emergency brake for the pancreas. It steps in and directly stops the pancreas from secreting any more insulin, finally turning off that runaway production at the source.
Okay, for our final puzzle, we're talking about insulin itself. Now, an insulin overdose might sound simple, but it actually creates this state of really prolonged and highly unpredictable danger.
And if you want to understand just how significant this risk is, get this. Among older adults, a whopping 95% of emergency hospital trips related to insulin are because of one thing: dangerously low blood sugar.
And what's really scary is that the danger isn't over just because they get the patient's blood sugar back to normal in the ER. One study found that 41% of these patients had their blood sugar crash again anywhere from 5 to 39 hours later. That means the risk can just hang around for more than a day.
Now, here's something that's totally counterintuitive. With most poisons, you'd think the bigger the dose, the worse the outcome, right? Well, with insulin, that's not always the case. People have actually survived massive overdoses. Survival often has less to do with the amount they took and way more to do with how fast the problem was caught and treated.
Okay, so picture this. A patient is rushed into the ER with dangerously low blood sugar. Is it an insulin injection? Is it a sulfonylurea overdose? Or could it be something else entirely? To get to the bottom of it, doctors have to do some brilliant biochemical detective work.
And the master key to this whole mystery is a little molecule called C-peptide. See, when your pancreas makes its own insulin, it releases insulin and C-peptide in a perfect 1-to-1 ratio. So you can think of C-peptide as the manufacturing receipt. If your body made the insulin, there's always a receipt.
And this is the smoking gun. Injected insulin, what doctors call exogenous insulin, is pure. It doesn't come with that C-peptide receipt. But a drug like a sulfonylurea forces your body to make its own insulin, which means it produces both the insulin and the C-peptide receipt. This one simple difference is how they unmask the culprit.
So this is the final reveal. If the lab tests come back and show high levels of insulin but low levels of C-peptide, the receipt is missing. That means it was an insulin injection. But if both insulin and C-peptide are high, the receipt is there. The body made it, which points the finger directly at a sulfonylurea. Case closed.
So when you take a step back, you see that each of these life-saving medicines presents its own unique and really tough challenge in an overdose. You've got the vague, deceptive symptoms of malaria, the paradoxical rebound effect of sulfonylureas, and that prolonged, recurring danger from insulin.
And all this really leaves us with one final thought to chew on. The fact that these overdoses are such complex puzzles is a powerful reminder of just how potent these medications are. It really underscores how critical it is to be safe with our medicines and have clear, open conversations with our doctors, not just in a crisis, but every single day.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.